Yeah, thank you, Vinay. Please do consider giving some refreshments to whoever is there. Please do consider giving refreshments to whoever is there so that it will not be an empty hall. Okay, so I will show some demonstrative cases. I think there is Cornea Rheumatology Connect has to be really strong if you really want to do ocular surface practice. So this is the story of a 70-year-old lady who came with drop-in vision of 1 week duration. She gave a history of loss of vision in the right eye following cataract surgery about 2 years ago. On examination, right eye was thumbsical, no perception of light was present. In the left eye, there was no tear meniscus. The paracentral cornea showed area of thinning with a punched out lesion and a lot of punctate erosions around that. As you see, the lid margins are bad, and absolutely there is no tear film. Tremors were 2 and 5. Impression, thysis bulbi, the sterile corneal melt with severe dry eye. So we treated with the CMC eye drops 1 hourly, doxycycline, lacrimal plug, and an emergency room at consult. Systemic examination was underwarding. Blood routine showed a very high ESR. ANA by immunofluorescence was positive 3 plus. Rheumatoid factor was 320. Normal values are less than 10. So the diagnosis was pretty obvious. Rheumatoid arthritis. Patient was admitted because she was one-eyed. We thought we'll pulse her with IV methylprednisolone and followed by systemic steroids, 1 milligram per kilogram. She turned around within 3 weeks and went back home. So this is that presentation at the time of presentation and after 3 weeks. So sclera and cornea has collagen, mainly type 2 collagen, type 5 is also there, some 6 collagen is also there, but mainly type 1 collagen with and proteoglycans. So as in any other connective tissue disorder which affects the collagen, their vasculitis can come here also. So obviously most of the findings of vasculitis like vascular occlusion, infiltration and fibrinoid necrosis would be seen if you do a histopathology. And if you look at more carefully under the microscope, you can see the immune complex deposition and consequent complement fixation, giving rise to pictures like this. You have a classic peripheral ulcerative keratitis with limbal inflammation, angry looking vessels right at the limbus, and you have a gutter in the cornea. And the diagnostic thing is you can pass a 26 gauge needle underneath the overhanging edge of the corneal ulcer. Something similar what I described in the paracentral lesion that you saw. Scleritis also is a manifestation of vasculitis. So it is very important to distinguish this particular entity from some other peripheral corneal pathologies. In almost up to 50% of cases, it can be the first manifestation of a systemic pathology, and that we have to bear in mind. I think a lot of physicians, even some of the rheumatologists, may not be really aware of the peripheral cornea and scleritis. They may know about scleritis, but peripheral corneal or PUK as a presenting feature can be a rare thing for a lot of them. We have a lot of physicians who have done rheumatology fellowships for 3 months or 6 months. I'm talking about people like that. If you have done in institutes where they see a lot of real vasculitis cases, they would have had experience with patients like this. So peripheral corneal disease for maybe for residents can be microulcerative peripheral keratitis or macroulcerative. If you see macroulcerative, that is a more severe form, and necrotizing scleritis, that usually denotes a severe form of underlying vasculitis. And in Foster series, what they saw is that if you don't treat it properly, more than 50% will die within 10 years. And if you treat it, most of the mortality can be taken care of. So what will you do if you have a patient like this with a peripheral corneal infiltrate and an ulcer? First thing that you think of is a Moran's ulcer in an ophthalmic setup. So how do you distinguish whether it's Morens or PUK? So you have to look around the cornea. You look for any evidence of pole scleritis like scleral thinning. You can see the faint, the choroidal show, which is an evidence of all scleritis here. In which case it should be a PUK. Sometimes it can be a very severe form of dry eye seen like this, or filaments, or sometimes beyond the cornea you can see the choroidal show. Or it can be sclerosing keratitis. The peripheral cornea can show some widening adjacent to an area of scleral thinning. So if you have a PUK, the treatment is basically the treatment of the underlying disease. It can be steroids. In bad cases, it should be a pulse steroid, and that too as an admission. IV methylprednisolone should be given. Sometimes along with that, cyclophosphamide need to be given. From our side, topically, what we can use is liberal preservative-free lubricants and maybe plugs for the sudden increase in the tear film that is available. You can also consider suppression of the ulceration and tectonic support by doing a peritomy along with the cyanoacrylate glue. So the Morens, it is the cornea-associated antigen. In PUK, it is other autoimmune disease, and it is getting manifested in the eye. That's all. So the features-wise, Morens and PUK are exactly the same. Only difference is other contiguous area also might show some evidence of scleritis or some dry eye, which is suggestive of a PUK. And as is seen quite often, in Morens, the treatment is topical. You just give topical steroids, most of the cases will come around. And if you do a peritomy plus glue, that is, you remove the blood vessels which are carrying the antibodies and you create a barrier there by putting a glue, then you can take care of Morens pretty well. If that fails only, you go for systemic steroids and systemic immunosuppression. While in PUK, the treatment is basically systemic immunosuppression. First thing is you give steroids and then only think of other things. So even though we can call these two watertight compartments, there are certain diseases which come in between. There is something called an undifferentiated connective tissue disorder, in which some features of some particular connective tissue disorder is present. And generally there are certain inflammatory markers are present in the blood. There can be a mixed connective tissue disorder also. There will be overlap between multiple diseases. Like it can be termed an SLE, it can be called a Sjogren's also. Then the other major entity is a disease in evolution, which is when you have these disease and you do the blood workup, you see that it's negative, other than slight increase in the CRP or ESR. But none of the other markers would be positive. So such people, if you follow up them for 5 years, 10 years, sometimes after 10 or 15 years, it might throw up a positive result. So that is disease in evolution. So Morens can be taken care of pretty well with a peritomy and a tissue adhesive plus bandage contact lens. If you don't treat it properly, sometimes it can rip through the cornea like this. So you can't give steroids in the long term. So you have to use some agent which basically are steroid sparing agents. So the things which we commonly use are methotrexate, azathioprine, and in our Indian context, mycophenolate is much more preferred. One, because the profile of side effects that it has is much less. Second thing is it is almost as effective as other agents and it's slightly less expensive. Biological agents like inhibitors of IL-1 or TNF-alpha, like infliximab or rituximab or now adalimumab, and some of the newer agents have also come up which are even more specific. So this is one case to demonstrate that a 44-year-old lady with a histopathological diagnosis of vaginous granulomatosis with bilateral CSOAM. She had even cavitary lesions in the chest. She had 6 pulses of cyclophosphamide and steroids and optic neuropathy even while on treatment. So this is a typical scleritis along with 360 degrees PUK. So one eye was lost because she had a granulomatous lesion in the apex of the globe, which is compressing on the optic nerve. And she came quite early now because she had this. And in the metro city where she was taking the treatment, she didn't get enough relief. the lab parameters, ESR, CRP, everything was high, CA ANCA was positive. So this is a lady who was on maximum dose of maintenance steroids, maximum dose of azathioprine, and even a mycophenolate, she is almost on maximum doses. Still, she is getting a recurrence. So what do you do? So in such cases, biologicals have come as a lifesaver. She was initiated on rituximab, and after just 2 injections, she came around. And she has been under follow-up for more than 10 years. This is one case I had seen around more than 10 years ago. Even now, she is taking on a small dose of azoran 100 milligram per day, and prednisolone 5 milligram on alternate days. So 5 milligram cannot be considered a significant dose. I think up to 7.5 can be considered a physiological dose. So you can actually do a patch graft once you control the systemic inflammation. I'm not going into the details of the patch graft for this audience, but if it is pretty localized, you need not be limited by the roundness of the trephine that you have. You can actually custom make a graft. So you can exactly make you can make a template of the graft, and same thing you can cut from the donor button. You can, as far as possible, you should make it a lamellar graft and suture it. And this patient came up later, about 2 or 3 years later, for a cataract surgery, and the graft was sitting like this. So these were 2 very straightforward cases. This is another case in which a 28-year-old manual laborer who's working in a fruit shop came with irritation and foreign body sensation, no redness or decrease in vision that he reported. So he had a past ocular history of redness irritation. He was diagnosed as PUK in the same institute. He was put on topical and systemic steroids, and he came around during that time. And he was almost symptom-free. He was symptom-free for more than 1 year. So these are the 3 illustrative pictures of his other eye, fellow eye. In this eye, he had a crescentic lesion in the peripheral cornea with collagen destruction and a descemetocele and associated limbitis. The left eye showing the peripheral corneal scar. Investigations were perfectly normal. ESR, CRP, everything in normal limits. Even in the initial period, he was investigated and ANCA was negative. So he was again evaluated by a rheumatologist. I think they spent more time on the systemic examination, but again could not find anything. So this patient was again started on systemic steroids along with methotrexate and lubricants. But the lesion was progressing during this period. The cornea got thinned out, started on topical steroids also, and he was in this, when the cornea became more than 90% thin, I suggested a tissue adhesive plus bandage contact lens as soon as possible. But he was not willing, and he came away a few days later with corneal perforation with an iris plug. It was during the COVID time, and we could not get any tissue during that period, and we did a multi-layered amniotic membrane graft. This is the graft, I think, 2 or 3 years late, 2 years later now. It's like a failed pterygium surgery. You can see the conjunctival vessels coming up to the area, but the cornea is well sealed and the vision is maintained. This is another case of a security guard who had a refractory PUK. I'm afraid my resident has not drawn it properly. So this is the cornea. I think we didn't have the anterior segment photography during that period, so the pictures properly could not be taken. So the lower panel shows the picture of the patient. The cornea was really ectatic. Actually, almost more than 270 degrees, he had a cornea like that, 270 degrees. Only in the upper 1/4 to 1/3 area, cornea was normal, but that area had a lot of superficial vascularization. So the patient was treated in a super specialty eye hospital. The patient had received, I think, cyclophosphamide, and his renal parameters were not doing well, so he was referred here. So he took rituximab injection cyclophosphamide also, and then after somewhat control of the disease, we took up the patient for a lamella keratoplasty. Actually, do we have a pointer? So I think uh, four grafts were used. Uh, so I think 1, 2, 3, and 4 grafts were used. Upper part, the resident cornea was present and an amniotic membrane was placed. Patient, as the membrane dissolved, had 6/12 vision. Now I think almost 1.5, 2 years later, patient has an early cataract but has got somewhat normal vision. The patient has 6/9 or 6/12 vision. The patient is maintained on tab methotrexate 20 milligram per week. He's taking, I think he has already received 2 rituximab injections. After that, because of the expense, he is not taking it, but he is under regular follow-up. So I think I have just one more case I just want to show. This is a 65-year-old lady, one-eyed lady who had a history of mouth ulcers. She lost her eye about 5 years ago, and the cornea was looking like this. And when the disease started affecting the left eye, she came to us. She had a very inflamed eye. Actually, the surface was wet, but if you see, there was subconjunctival fibrosis, the corneal cell shortening, limbal stem cell deficiency, blood vessels approaching the central cornea. We took the patient, I think the histopathology was done, it was suggestive of a lichen planus. Sorry for the spelling mistake there. So after 2 months, she was put on cyclosporin and topical tacrolimus. She could not take another drug because being 65 and her liver parameters were not perfect. So they were not really willing to give a second drug. So the patient was only on tab cyclosporin and on tacrolimus. And after about 2 months, she's like that. She's maintaining vision. There is a around 5.5 millimeter island of cornea, which we are trying to preserve. Another somewhat similar lady, redness, pain, foreign body sensation for 1 month. One eye lost. The other eye, she had basically a cicatrizing conjunctival disease, some amount of keratin over there. And you can see that there is a corneal melt in the central part. So by the time we got the workup done, she had developed a descemetocele, for which I had to do a cyanoacrylate graft with glue. And later, she developed a total cataract because of the systemic steroids, and even before she had some amount of cataract. So she absolutely had no vision. I was not in a hurry to do keratoplasty. I didn't want to do, but she wanted some vision, and I was forced to do a small keratoplasty for her. And as of now, she's doing okay, but it's hardly 3 months after the diagnosis. Her disease, her eye appears much less inflamed now, but she's under regular follow-up. So these rheumatological, the corneal diseases, especially surface disorders and this vasculitis, we do need the rheumatologist to manage this. I think, and as ophthalmologists, we cannot manage it alone. And the systemic side effects of these drugs are very severe. It is quite often a game between the side effects of the drug and losing the vision. So we have to strike a fine balance. But having said that, prompt immunosuppression is a must. We do need a good rheumatologist who can understand us, and we have to work in tandem with them so that we can manage the patient successfully. Surgical repair can be considered only after adequate control of the systemic condition. Thank you.
Thank you, Dr. Anil. May I request Dr. Anita to come over to the stage, please? Anita, Dr. Anita.
Anita Jabbar.
Can you please come over? Yeah, so a very quite exhaustive, array of cases, most of them very difficult to manage. So before we proceed to the next talk, can we have some questions if there are any for Dr. Anil?
Okay, so I think we should look at the basic collagen workup. That is blood routine, which obviously should include the ESR, a C-reactive protein, which can be considered an ESR for a connective tissue disorder. Then ANA and RA factor bare minimum. ANA, I would prefer that you do an immunofluorescence. A lot of tests do only a qualitative assessment, and that depends on the lab also. If you do immunofluorescence, they'll put it as 1 plus, 2 plus, 3 plus. So if you have 1 plus, maybe it is ignorable, but if you have 3 plus, you cannot ignore it. Then RA factor also should be assessed. This is the basic minimum thing. Then I would suggest it's better that you get it evaluated by a physician or a rheumatologist who has a good know of things. And depending on the symptoms of the particular thing, you have to investigate accordingly. If you have some suspicion of vaginous, you have to do P-ANCA, C-ANCA and stuff. If you have rheumatoid arthritis in mind, you have to do anti-CCP and other tests. I don't know, a lot of array of tests are there, which a lot of them I also don't know because it is their subject expertise. But the basic collagen workup is mandatory. If you see that everything of at least these 4 are normal, it's less likely that it is a connective tissue disorder. Then you can treat it more confidently by local means.
So you would reserve the CNK and PNK later, or
Yeah, I usually reserve it I think also it depends on the clientele that you're dealing with also.
Please.
So you mentioned that 50% of the patients who present to us may not have had any other thing to suggest that there must be an immunological systemic disorder in place. So do these patients, in your experience, sir, like who have not had any history, do they have any eye symptoms which can indicate towards it, or have you seen these virgin eyes come with perforation which have really turned out later on when you did the immunological workup, have picked up the sign later?
Okay, that's a good question. But I think I think only thing what we can look for in the eye is, as I mentioned, look for dry eye, evidence of old scleritis. A lot of patients, they do not come up with proper history. Then obviously history of joint pains, waxing and waning, then some other things like that. But as I said before, a lot of these patients just can come de novo, and then you are in a fix. So unless you do a blood investigation and get it evaluated by a rheumatologist, we cannot know. I think it's not just ophthalmologists who are facing it. I think ENT surgeons, they see rarely this OCP and all coming only in the larynx. So such things are, even in textbooks it is not properly described, but they do see such patients, which are rare but possible.
Anil, I have a few patients who are having rheumatoid arthritis, severe dry eye, undergone PK, and sometimes at times coming with exacerbative ocular surface inflammation. And what are the guidelines for that, for such patients? If you happen to do a PK for them, and what are the extra? Do you use high dose cyclosporin, or
Okay.
omega-3 fatty acid is?
Okay. So a lot of rheumatologists consider omega-3 fatty acids are placebo. And if you are using it, have to use it at least 1.5 gram per day to have some anti-inflammatory effect. And there is a school of thought that if you use omega-3, that changes the microbiota, and that's why this inflammation is getting less. So anyway, if you're using it, you have to use 1.5 gram per day. But one advantage with rheumatoid arthritis is if you give immunosuppressants, it is good for the graft also. So I think you have to err on the side of treating the inflammation by giving more immunosuppression. I think if it is a patient in whom it's a burnt out disease and you see that there are no other symptoms, quite often the rheumatologist will not treat it. Because it's not that the disease is not there, but he doesn't want the patient to unnecessarily have the side effects. But I think in this scenario, you have to insist of the rheumatologist that you have done a graft, it needs more care, and we want to be more careful about the ocular surface, and we don't want recurrence of the disease. In such a case, we can suggest them, and often they will oblige.
So the crux here is that we should have a very good rapport with the rheumatologist, and they should be willing to accept our arguments, why
That is the main
why,
challenge.
why the the immunosuppressive status has to be hiked or changed.
So when they see only eye there is some redness, they don't really believe you. So you have to develop a rapport with them. It's difficult.
Exactly. So that is the most difficult part which many of us face. So yes, thank you, Anil. That was
Thank you. Thank you again for the
wonderful,
opportunity.
wonderful session. I will say that alone.